A very good evening to all of you. So this is our 10th episode of NextGen mock examination. And this time we have a pattern of like 45 minutes for a long case, which is a case of PUJ obstruction, going to be presented by Dr. Shreya Rai. And rest of the 50 minutes will be dedicated to a short case, which is going to be a surprise short case. And with us, we have two very senior professors of the country, Professor Dr. J.K. Mahajan from Chandigarh and Dr. Archana Puri, professor in New Delhi. So I hand it over to Shreya for her presentation, and examiners are free to ask the question as and when they desire.
మేడం ఎంత వాళ్ళు ఎత్తారు
I request other people to mute themselves. Those who are not talking, please mute themselves. Yeah, please share.
Thank you, sir. A very good evening to all. So we'll head with the details of the case. So a 4-month-old male baby was brought by his parents to our OPD with the chief complaint of febrile episodes since 2 weeks and cry while micturating occasionally since 2 weeks. So his fever was low grade, undocumented, occurring once in 2 to 3 days with no diurnal variation and was not associated with any chills. While other than crying while micturating, there was no history of frequency, straining, dribbling, hematuria, no episode of urinary tract infections during the last 4 months, and there was no history of any bowel complaints like constipation. Along with fever, there was no history of cough or rapid breathing, any rash or generalized weakness, no history of any jaundice, vomiting, or altered sensorium, and no history of refusal to feed or failure to thrive. So the antenatal history was that it was the couple's first pregnancy. Child was born out of spontaneous conception. The pregnancy was not booked or supervised. The parents told that a level 2 scan was done at 8 months of gestation, which revealed a swelling in left kidney, but they were reassured that it is mild and it will resolve spontaneously. In the past, the baby had no episodes of febrile urinary tract infections or any other illness requiring hospital admission. The birth history of child baby was term, normal vaginal delivery, cried immediately after birth, was of weight 2.5 kilos, discharged on day 1 postnatally, was breastfed, had a smooth perinatal transition, passed urine in good stream 6 hours after birth, and also passed meconium within 24 hours. The growth and development of baby was as per age, was immunized as per age, and baby was born out of non-consanguineous marriage and first baby with no similar complaints in family. So this was the history. Then coming on to examination. On general physical examination, the child was active, playful, afebrile, and well nourished. His vitals were stable with a heart rate of 90 beats per minute, a blood pressure of 80/60, which was within 75th percentile, and a respiratory rate of 22 breaths per minute. There was no pallor or edema. The facies was normal, and anthropometric parameters were weight of 5.5 kilo, which was within +1 standard deviation, while height was 15 centimeter, which was within -1 standard deviation. On local examination on inspection, the abdomen was protuberant with a centrally placed umbilicus. There was no localized fullness, no scars, pigmentation, or dilated veins. Hernial orifices were free. On palpation, the abdomen was soft, non-distended, with no local rise of temperature. There was a well-defined lump palpable in left lumbar region of 4 into 5 centimeter. It was smooth in surface, globular in outline. It was non-tender and not palpable bimanually. And I could insinuate fingers between the mass and the left costal margin. There was no impulse at hernial orifices on crying, and bladder was not palpable. On percussion over the lump, there was a dull note. Also, a dullness was appreciated over the renal angle, and the liver span was 6 centimeter with no evidence of any free fluid. On auscultation, bowel sounds were present. Then on systemic examination, his spine, extremities, and genitalia had no abnormality. There was no evidence of phimosis and bilateral testes were descended. Chest and cardiovascular examination was within normal limits.
So, Shreya, you can stop at this point.
New building used.
All participants who are not speaking, please mute your mic. Participants who are not speaking, please mute your mics. So, Dr. Shreya, so now, yes, go on to next slide and summarize your case, like positive points in history, examination.
Okay, sir.
Go on, yes.
To summarize the history and examination, it is a 4-month-old first male baby who is well nourished and active with antenatally diagnosed left side hydronephrosis who presented with complaint of fever and crying while micturition. There is no other history of lower urinary tract symptoms or constipation or other systemic involvement. And the examination revealed a well-defined smooth globular lump of 4 into 5 centimeter, which was not bimanually palpable in the left lumbar region, which is probably a renal lump with a while the child was developmentally normal, immunized as per age, with no significant family history.
Okay. So, Dr. Shreya, this was antenatally diagnosed, and the parents were told that baby has left hydronephrosis. But he came to you at 4 months of age. So, can you elaborate for the benefit of the audience that why this was so?
Yes, sir. The parents, first of all, the pregnancy was not booked and supervised. The parents got a single ultrasound at 8 months of gestation. They were told that there is some swelling in left kidney, but also they were reassured that it will resolve spontaneously with time. So, and also they were told to notice urine stream and notice for any urinary complaints after birth if the child has. So since the child passed urine and good stream and there were no symptoms at birth, so parents kind of delayed and did not seek any medical attention till the child had symptoms.
Dr. Archana, are you like online? Do you want to ask something?
Yeah, I'm listening to her. So, Shreya, this was an antenatally diagnosed hydronephrosis. Did you have access to the antenatal ultrasound report? What
Yes,
does they
ma'am.
read?
Yes, ma'am. I have. I will come to the antenatal. So I asked the parents to show their antenatal reports. So it was done at 31 weeks of gestation, a single live intrauterine fetus with Liker adequate. The face, thorax, abdomen, spine, and extremities of the fetus was normal. And on the KUB, the left kidney was reniform in shape with a dilated pelvis of 12 mm. The cortex they commented was normal with a normal ureter. While the right kidney, the shape, cortex, ureter was normal with a non-dilated pelvis and a normal appearing urinary bladder. This is what they commented in the antenatal report.
How much was the APD you said? Sorry.
12 mm.
What was the measure?
Dr. Archana, you are not clearly audible. The question, please. Dr. Archana. Other members of audience can also ask questions in the chat box. Please, and if anybody has any questions, please ask in the chat box. So with this history and examination, can you like go to any differential diagnosis you made?
Yes, sir. Since it is also antenatally diagnosed as well as on examination, patient has presented with urinary symptoms, and on examination there's a lump which feels more like a renal lump. So my first DD would be a left side hydronephrosis. the most common cause of which can be either a pelvic junction obstruction, and following which less common causes can be vesico-ureteric reflux or a vesico-ureteric junction obstruction. Very rarely, a multicystic dysplastic kidney can present with a lump, but it is since the child has urinary symptoms, we are keeping that DD. Otherwise, the lump is not in favor of an multicystic dysplastic kidney, and very rare can be a neonatal renal tumor since a lump is palpable, but it is one of the rare possibilities. I would like to go with a DD of left side hydronephrosis, probably due to a pelvic junction obstruction.
So, as Archana madam is still joining, I have a question for you. How will you differentiate a PUJ obstruction lump from any other renal lump? Is there any particular feature of such a large PUJ which you can appreciate clinically with your palpation?
Yes, PUJ lump, as the pelvis is ballooned out, it will be a globular lump with a smooth surface and with a globular outline, and it is well palpable, a well-defined kind of.
Something more, that PUJ, that pelvis and kidney, do they appear like smooth or there is something between the two? I'm talking about those lumps which are like bigger PUJs, bigger
Okay,
PUJ.
so in that case, between the parenchyma and the pelvis, kind of indentation kind of can
Yeah,
be.
that we call it step. So you get a step there between the pelvis, dilate balloon pelvis and the kidney. So that's how you can differentiate that it's a PUJ lump or something else. Please go ahead.
So secondly, multicystic dysplastic kidney, a lump is a common presentation or uncommon presentation?
It is very uncommon, sir, since the kidney will be shrunken. So just because this patient had UTI and antenatally there might be some hydronephrosis, but postnatally the kidney shrinks. So it is a very uncommon presentation to have.
Okay. One of your first diagnosis is left hydronephrosis. You have put up 3 causes. How did you rule out PU valve in this particular case? You are right in ruling out PU valves. What are your reasons for not considering it?
So based on antenatal presentation in PUV, usually there will be bilateral hydronephrosis with a prominent can be prominent ureters with bladder changes like a small bladder with wall thickness, or there might also be oligohydramnios or ascites. So these are points favoring PUV. And then in history, the urine stream at birth will help suggest there might be poor stream or poor stream or intermittent passage of urine, or a visible suprapubic fullness. So they'll suggest more of a PUV.
So
Yeah, sorry.
normal urinary stream at birth more or less rules out PU valves. Yes, Dr. Archana, please.
Shreya, I was asking you, based on your antenatal ultrasound, your APD was 12.5. How would you grade the severity of hydronephrosis in this baby?
Yes, ma'am.
How would you prognosticate this mother antenatal ultrasound?
Yes, ma'am. We can first we can grade hydronephrosis as mild, moderate, and severe. And also we have to see for gestation if it is less than 28 weeks or more than
What
28
is this child? I'm talking about this child. 31 weeks, 12.5, with no oligo, unilateral hydronephrosis. What would be the prognosis? What would you put as a grade?
It is a moderate hydronephrosis, ma'am.
Is there any?
Then will you call it a severe hydronephrosis at this particular gestation?
More than 15 mm is severe hydronephrosis.
Yeah. So besides looking at what are the should look at on an antenatal ultrasound if available to see the severity of hydronephrosis antenatally diagnosed?
Yeah. One can appreciate calyceal dilatation, then see for renal parenchyma thickness, then ureters have to be sought for if they are dilated or not, then changes in bladder, and liquor has to be seen adequate, or if there is oligohydramnios. Also, there can be presence of ascites, which is a poor prognostic marker.
I would add one more: loss of CMD, corticomedullary differentiation, and presence of renal cortical cyst. These are bad prognostic markers. So if you are seeing renal cortical cyst and there is a loss of CMD on antenatal ultrasound, besides the features that you have enumerated, then we have to be little guarded in that. So another question to you would be, on an antenatal ultrasound, where do you measure the renal APD diameter?
The renal APD has to be measured at the in the transverse plane at the level of renal sinus, and the position of even the plane should be as close to the spine as possible. In transverse plane, we can see different diameters, but the maximum diameter will be the APD for that patient.
Right. Dr. Mahajan, can I proceed, or you want to ask something?
No. Let's go further.
In your history with this antenatal ultrasound finding, when you were enumerating the positive and the negative findings, you had taken history for convulsions, rashes, and things like that. So can you explain me the significance of those?
Yes, ma'am. Since the child had fever on and off since 2 weeks, so to rule out other systemic illnesses, I took history of rashes and altered sensorium to rule out basically any fever with rash or meningitis or pneumonia. I took that
Okay.
history. Yes.
Okay, fair enough, right. So suppose on an antenatal ultrasound, ureter was dilated in this child, then what would have been your interpretation, and how you would have varied in your postnatal assessment?
Yes, ma'am. If ureter is dilated, then I will suspect presence of also vesico-ureteric reflux. So postnatally, after 48 hours, I will repeat an ultrasound KUB to see for the persistence of hydroureteronephrosis. And if it is there, I'll start the child on antibiotic prophylaxis, as well as we repeat the ultrasound at 1 month. Still, if it is persistent, we go for an micturating cystourethrogram at 6 to 8 weeks of age.
Okay.
Postnatally.
So this child had a cystic lump in the abdomen when you had mentioned the lump. Was it a cyst? What was the consistency of the lump? It was cystic or firm, or what was it exactly?
Firm kind of lump, ma'am.
Okay. So your provisional diagnosis would be?
First diagnosis will be, ma'am, a hydronephrotic kidney, probably
Cause?
most commonly due to pelvic junction obstruction.
How would you explain the presence of fever and other infection? What could be the causes in a PUJ which can lead to this type of symptomatology that your baby presented with?
They can be urinary tract infection when there is urine stasis.
Right.
And we
Any other
have to
cause?
rule out vesico-ureteric reflux in such cases, as there may be
In what percentage of patients of PUJ will be an associated VUR may be present? Is it a common finding, or it is
less common? 9 to 14% of cases can have VUR along with PUJ.
So, as is the case in your child, where the infection history is present, fever and dribbling and all that, and culture is also positive in this child?
Yes, ma'am. We got a urine RMN.
She will talk about investigation. Now, she has just talking about the differential diagnosis.
Right. In such a child, you are having a history of fever with a renal lump, and you are thinking of PUJ. How would you plan your postnatal management, your postnatal investigations?
So we will ask her. That is our next question to her. That she had made a differential diagnosis. Let's now ask her that what she will do next. There are two scenarios, Dr. Shreya. One is antenatally diagnosed and patient comes to you immediately after birth. Another scenario is patient doesn't come to you, he comes to you with symptoms at 4 months of age. So first you answer that if the baby comes to you immediately after birth, parents tell that patient has antenatal hydronephrosis, what will you do? And then you tell what will you do in this patient. Okay. So yeah.
If they come post-birth with an antenatal diagnosis, we have to repeat an ultrasound of kidney, urinary bladder between 3 to 7 days of life. And if there is hydronephrosis in that, we have to see if it is mild, moderate, or severe. If it is mild, another ultrasound can be repeated at 1 month. And in case of mild, we can hold with uroprophylaxis. Like we can wait. If child has been asymptomatic, passing urine in good stream, the parents are advised for preputial hygiene. And 1 month, we can repeat an ultrasound and see for if the APD is increasing, the trend of APD. While if it is moderate to severe, we'll start on antibiotic prophylaxis. And again, we need to repeat an ultrasound at 1 month. But in case of severe hydronephrosis, one has to see for any ureteric dilatation, and if present, we also have to plan for a VCUG. If in this case,
No, sorry, continue. Please continue. Sorry.
In this case, as child has presented late, first we will go with basic investigations, CBC, RFT, a urine RMA culture, and an ultrasound kidney urinary bladder to see for the present status of the hydronephrotic kidney. And then depending on the findings, we will proceed.
Okay. So what was done in this patient next?
So we did routine investigations, CBC, RFT, which was almost within normal limits, and a urine culture was done, which showed Staphylococcus hominis. But it is usually a commensal of the skin, and since the child had fever and crying while micturition, as the child was symptomatic, that's why we gave him ciprofloxacin therapeutic doses, and then we repeated a urine culture, which turned out to be sterile after 2 weeks. And then we did an ultrasound of kidney urinary bladder, which revealed that left kidney was grossly hydronephrotic, 7 centimeter in size, with ballooned out pelvis and APD of 4 centimeter with a cortical thickness of 7 mm, and ureters were not visualized. While right kidney was normal and bladder was also appeared to be normal.
So what is your interpretation of this ultrasound?
So based on this ultrasound, it shows isolated hydronephrosis, which is gross, according to reporting, and ballooned out pelvis. So we will think in lines of pelviureteric junction obstruction as cause of the hydronephrosis.
So now if you have to grade this hydronephrosis, this will be what grade?
It will come under severe, more than 2 centimeter will come under severe hydronephrosis.
So Dr. Archana, questions on ultrasound?
Is there any other way of postnatally grading the hydronephrosis? What is an SFU grading, and what grade do you think, according to SFU, your child would be?
Yes, ma'am. SFU grading is Society of Fetal Urology. So they grade as 0, 1, 2, 3, 4. 0 is normal kidney, while in grade 1 there is dilated renal pelvis, but the calyces are preserved. While in grade 2, there is involvement of major calyces, few of the major calyces. In grade 2, even diffuse involvement of major as well as minor calyces occur. Also, the dilatation will extend beyond the renal borders, while in grade 4, there is thinning of the renal parenchyma. So here, cortical thickness is preserved, and actually in ultrasound, they did not mention about calyces. So if we had an idea, if only the major calyces are involved, then it will be grade 2. If minor calyces are also involved, then it will become grade 3. They have just commented on pelvis and cortical thickness.
You don't
Okay.
have an ultrasound?
No,
You
ma'am.
have done ultrasound now. These are the findings. What next you will do?
Yes. Seeing this ultrasound, I would like to proceed for a diuretic renal scintigraphy to rule out pelviuretic junction obstruction, as it is a case of severe hydronephrosis.
Okay. For the sake of audience and others, you tell now what are indications of doing diuretic renography in a case of antenatally diagnosed hydronephrosis. Do you subject all patients to diuretic renography, or you select patients for diuretic renography?
We selectively do diuretic renal scintigraphy if we see for the trend of APDs, if postnatal APD is in increasing trend as compared to the antenatal values, then if it is going from moderate to severe hydronephrosis, and diuretic renal scintigraphy has to be planned, especially when there are features like ballooned out pelvis or thinned out renal cortex.
Okay. So now describe the findings of renography in this patient.
Can you show us the images of renal scintigraphy?
Yes, ma'am.
Right.
I'll request Shreya, you have put some annotation by mistake, I guess.
I have not put this, sir. Somebody else has put this.
Because I am not able to rub them.
Yes, sir. Some Shweta has put this.
Who is Shweta? Kindly remove these annotation. Shweta. Okay.
We
Show
have
us the
Technician 99 EC scan. NF0 protocol was followed. In EC scan, sequential dynamic images of the abdomen are acquired in posterior view for 24 minutes under gamma camera. Immediately after injection of technetium 99, also injection Lasix, that is furosemide, is given at the start of study. We saw that in the left kidney function was 37%. That too was likely overestimated. The kidney was enlarged, grossly hydronephrotic, with severely impaired perfusion and poor cortical tracer uptake with a thinned out parenchyma. There was progressive pooling of tracer in the dilated PCS, and it was seen even at 5 hours of the study. While right kidney had a function of 63%, the function it was a good function with an unobstructed drainage. So these are the images. The first scan on the left upper corner shows the perfusion of the two kidneys. So here we can see that
All
a
participants,
tracer is
who are
uptaken by
not
the right
speaking,
kidney.
please mute your mic.
But since the left kidney is not well perfused, the tracer is uptaken very slowly in the left kidney. Then we follow the renogram curve. Here, the activity of left kidney is denoted by red line, while the activity of right kidney is denoted by green line. So, the first phase in renogram curve is the vascular phase, in which as soon as the technetium 99 is injected into is given IV, it is there are multiple cycles when the circulation the contrast is being taken up by the kidney. So this is the vascular phase. Then this phase is the uptake by the renal cortex, which is called as a functional phase, which is further this is the uptake phase for the right kidney, while here is the uptake phase for the left kidney. Then comes the elimination phase. So here we can see that the normal one, the right kidney, uptakes the tracer by almost less than 5 minutes, and then it is excreted. While there is persistent contrast in the left kidney till the end of this acquiring these images. So normally the tracer should clear within 10 minutes of study, but here we can see it is still persistent till the end. And
what is the T-half of the normal kidney?
yes, ma'am. T half for the right kidney is 17 minutes. T half
Can you
means
tell me?
that, yes, ma'am, the time taken to empty half of the tracer. So for the right kidney, it is 17 minutes. Maybe the child was not well hydrated. Normally, it should be less than 10 to 15 minutes. While the
When do you say it is obstructed? If
if
T
it
half
is
is more
within
than what?
20 minutes, then it is called as obstructed. Here in this in these parameters table, they could not mention T half since the tracer was there till 5 hours of the study. Also, in
Right.
this, we can see
Shreya, what is fallacy of T half in a dilated system?
in a capacious or dilated pelvic calyceal system, the tracer tends to pull up, and then there will be prolonged T half, and this will give a false positive impression of a pelvic junction obstruction.
So in a renogram, is it one parameter or multiple parameters you look at to make a diagnosis of obstruction?
Yes, we have to see for split renal function, and then mainly two things, the function and the drainage. So we see for split renal function of both the kidneys, and then we see for the drainage pattern of those kidneys. Also, we can appreciate here perfusion of the two kidneys, and renal transit time can also be calculated.
So these are like multiple findings you look at on renogram also. So cortical uptake, then transit time, then clearance, then differential renal function. So for the sake of audience, there must be some postgraduates, many postgraduates sitting. How do you find out differential renal function? What is the method of calculating it?
So we calculate differential renal function by seeing the radio tracer is calculated as counts. It's as is applied
By drawing ROI. So
region of
what
interest.
I'm trying to ask is ROI. Okay, so you will draw region of interest over each kidney, and then by computer calculations, you find out the counts, and that gives you differential renal function.
So can I add one question to your comment, sir?
Yes, sir, please.
Yeah. What area of the kidney you will include in ROI and in what phase of the study?
We have to include the pelvic junction, sir, mainly.
You basically include the parenchyma, and during the cortical uptake phase, you have to calculate that. Otherwise, what will happen if you take it later on, when the tracer has already pooled in the pelvis, then you will have falsely high differential renal function on the affected side.
Yes,
It's a
sir.
very common finding in reports. I mean, if it is taken later on, because this is usually done by technician. So this point you have to be aware of, because at times in PUJ obstruction, you see more function on the affected side. It's difficult to explain to the patient that function is more on that side. Okay.
Okay. So,
Besides, sorry.
yes, Dr. Archana, please.
Yeah, besides the explanation that Dr. Vikesh has given for supranormal function on the obstructed side, are you aware of any other explanation which can explain a supranormal function on the obstructed side?
What hyperfunctioning kidney is one theory given, but it is not accepted presently now.
What is the role of activation of renin-angiotensin system in giving this supranormal function? Are you aware of anything like that?
No.
Are you aware of captopril renography being done in such patients? So this is a food for thought actually. Sometimes when these babies have supranormal function, besides the function being sometimes being calculated wrongly by plotting a wrong ROI, it could be that in these patients the renin-angiotensin system is activated. That will only be activated in an obstruction which is very significant. So there are studies. We did one study in All India Institute where we used to do a renography, ETPA scan prior, and then in order to unmask the renin-angiotensin system, we used to give captopril and repeat it again in the same sitting. So if in the post captopril renography, if you are finding a differential function loss of more than 10%, that means that RAS was activated in these patients. And the obstruction is significant. Whatever value you are saying is a significant obstruction, because RAS would not be activated in an obstruction which is not very significant. So this could be another explanation in these patients. So what was the differential function in your baby?
In this baby, it was 37%, but that was also, as mentioned, likely overestimated.
Okay.
You
So
have
suppose this child is not symptomatic and had not presented to you with lump. It was an antenatal diagnosed hydronephrosis, asymptomatic. Neither the child had lump nor the child had presented to you with infection. And the child had a differential function of 37%, as you are saying. Then what would have been your further plan of action in this baby?
Since the function, although this also is overestimated, but since drainage is obstructed, we need to monitor the APDs. We can go for a repeat ultrasound to see if the APD diameter is increasing. If it is an increasing trend, then definitely one has to plan for surgery.
Sorry.
So, Shreya, you have next image also. You can show that also.
Yes, sir. This in
Describe this.
every minute time frame, the EC scans in every minute time frame, a study was done for 24 minutes. Here we can see that the left kidney perfusion is poor, so the tracer is uptaken quite late, and while the tracer uptake in right kidney is within 1 to 2 minutes, and then we can see the tracer transitioning into the pelvis, and it almost empties by 24 minutes. This here also we have post-void picture which shows that the right kidney has completely emptied its tracer almost, while the left kidney has significant retention. This study was also done at 3 and 5 hours, which shows significant retention of contrast of tracer till 5 hours, suggestive of obstructed drainage.
So now summarize again after these two investigations.
So, 4-month-old, first male baby, well-nourished, active, with antenatally diagnosed left hydronephrosis, with complaint of fever and crying while micturition, with a left renal lump, with no other complaints. Developmentally normal immunized per age, as per age, with no significant family history, with imaging suggestive of left side hydronephrosis, probably due to PUJ. Means now cause etiology is PUJ with no vesico-ureteric reflux.
So in between, you missed one
MCS.
investigation. So question now is like everybody has there in mind is, then in antenatally diagnosed hydro. So in antenatally diagnosed hydronephrosis, question which everybody will have in their mind is, what conditions or what situations you will do voiding cystourethrogram or micturating cystourethrogram?
We will do when there is evidence of hydroureteronephrosis, or on SFU grading if it is a severe hydronephrosis of grade 3 and 4, or if the child has bilateral hydronephrosis which is persistent on postnatal scans, or if the kidney also has if there is hydronephrosis associated with a duplex or a ureterocele, or if there is a abnormal bladder, or if antenatal, along with antenatal hydrosis, child has postnatal history of UTI.
Okay. So Dr. Archana,
Right.
your
Yeah, in unilateral hydronephrosis, probably 3 indications we are aware of. One is if the child is having hydrouretero, ureter is also dilated along with hydronephrosis. Second is if the child is having UTI, as was the case in your child. And the third is if the child has a culture positive UTI, is carrying a report. SFU grade 3-4 hydronephrosis has been mentioned in American Association guidelines. But I would like to ask you at your center, in unilateral hydronephrosis, SFU grade 3-4, when you have done, do you do MCU in all patients if they don't have any of the other factors present?
No, ma'am.
And what
We
were your
do
grades?
we do not do MCU in asymptomatic severe hydronephrosis.
Right.
Only
So, yeah, if ureter is not dilated on, I will tell
Yeah.
this. Ureters are not dilated on ultrasonography, then even, and there are no histories of UTI, and on ultrasonography, the kidneys anomalies are not there, generally normal. So we don't do, it's not a routine for us to do MCUs.
Even we don't do it. Though the AUA guidelines states SFU grade 3-4 in unilateral SDN as a indication for MCU, but most centers in India, I believe, are not doing it. Even at our center, we don't do it. So MCU was normal in your baby?
yes, ma'am. MCU shows normal bladder capacity is normal. Outline appears to be normal with urethra. The posterior urethra appears to be very slightly prominent, but essentially the urethral diameter
I'm fucked up.
urethra appears to be normal.
Now, what will you do for this child? What
Since
will be the
So,
suggestion?
give your final diagnosis and answer Dr. Archana's question.
yes, for final diagnosis is antenatally diagnosed case of a hydronephrosis with postnatal
Move your slide on.
diagnosis suggestive of a left side pelviureteric junction obstruction. So
Management.
I would like to proceed. As I have already done routine investigations, and I would like to proceed for a pyeloplasty.
So now, what is your like approach and little bit about steps of pyeloplasty?
Approach can be either open, laparoscopic, or robotic assisted laparoscopic, laparoscopic assisted robotic pyeloplasty.
Keep in mind, baby is 6, 4,
4
5,
months old.
6 months old.
Yes, sir. So in open approach, we can go via anterior subcostal incision or a flank incision or a posterior lumbotomy incision. In anterior subcostal incision, a transverse incision is given in the subcostal region. Then the external oblique and internal oblique is cut, while transverse abdominis can be split. Then the peritoneum is gently swept medially such that we reach the retroperitoneum without breaching the peritoneum, and then the gerotas fascia has to be divided posterior and laterally, and then we can visualize the left side of the kidney. The also the position has to be supine with the roll kept below the left subcostal region. Then on visualization, first we need to pelviureteric junction has to be identified. One should try to minimally handle the tissues as it can cause devascularization of the pelviureteric junction and for later risk of strictures. So stay sutures have to be taken in the pelvis in superior and anterior location, while stay suture has to be taken in the ureter in the medial location. The it is
What is name of the operation?
it is modified Anderson-Hines open pyeloplasty.
dismembered pyeloplasty.
Yes, sir. Reduction, these days it is preferable to do for a large pelvis, it is preferable to do a reduction pyeloplasty. So the redundant pelvis is excised while the medial, while the lateral edge of ureter is spatulated till we see the healthy mucosa. So one can
What precautions you take while doing reduction, pelvic reduction?
One has to be very careful that we should stay at least 1 centimeter away from the calyces.
Okay.
Otherwise, we
Okay,
can
so that you don't obstruct calyces. What drainage? Drainage, what drainage?
the anastomosis should be wide, dependent, watertight, funnel shaped, tension free.
Drainage.
How would you ensure it? How would you ensure your drainage is dependent?
The anastomosis should be at close to the lower part of pelvis.
Your anastomosis should be the first stitch that you take, the lower end of the pelvis to the lateral end of the ureter. It should be in line with the inferior calyx. So normally once we have done the reduction, we take the stay stitch on the lower end of the pelvis in line with the inferior calyx, because that is going to be the most dependent part for that kidney. And your first stitch should come at that point, and then you just do whatever suture you have to use. Which suture do you use, by the way? In this child, which suture would you use?
We can use either Vicryl 6O, polyglactin 6O, or we can also use polydioxanone 6O. 7O.
What do you use? You are doing the pyeloplasty.
I would use 6O.
Okay. Continuous or interrupted?
Initially, we'll do with interrupted sutures. Once the lower part of anastomosis is established, the pelvis we can close with continuous sutures, while the lower part of anastomosis should be done with interrupted sutures.
Okay.
Okay, and do you?
So, Dr. Archana, there are some questions in chat box, and
Yeah, please.
differential diagnosis of urinary tract dilatation, she has already answered. Then antibiotic prophylaxis in unilateral hydronephrosis.
Mild cases of hydronephrosis, antibiotic prophylaxis can be held if the child is asymptomatic with a good urinary stream and parents are able to maintain a good preputial hygiene or perineal hygiene in case of female.
So, SFU grades, higher grades 3 and 4, you give antibiotics. Lower grades, you may not. And then one interesting question, IVP, role of IVP in PUJ.
Yes, sir. When on ultrasound, the kidney is either ectopic or malrotated, or there are some anatomical variations. In that case, IVP is, or if there is a Doppler done which suggests crossing vessels, then IVP is useful in pre-op planning of our surgical approach, our incision, because sometimes if the kidney is malrotated, the pelvis might be directed downward or posteriorly.
Okay. Dr. Archana, organizers are asking us to wind
up. One last winding up question. Okay. Instead of IVP, Shreya, we can do an MRU also with less ionizing radiation. And just tell me one thing. Suppose this child had come to you with lump as the baby did, and the differential function was only 8%. Then what would you have done? It was not 33%.
We'll give kidney a trial. We can do either a DJ stenting if possible. Otherwise, we usually do a PCN in our patients, and we see for the urine output and urine. We see osmolality, urine sodium, so which helps us to quantify the tubular function of the kidney. If it improves with time, then we can do a pyeloplasty for same.
Good. Well done.
Okay. Thank you, Dr. Shreya. So, Dr. Archana, we wind up and hand over to
right. Thank you, Dr. Mahajan.
Thank you, sir.
So 1 second, my screen is loading. There is some problem. His head has got hanged. So I had a case of male extrophy. Sorry.
We can't
A
see.
case of male extrophy here, which I'm not able to share because my desktop got hanged. So yeah, we can initiate some discussion on extrophy by the time my screen is loading. Hello, sir. Mahajan, sir.
Yes, please.
Yeah,
I'm
please
here only.
initiate some discussion on extrophy by the time my screen is loading.
Okay.
So,
Okay.
Shreya, what are the findings you would tell us if you are seeing a patient of bladder extrophy, male? What are the points that you would like to note on clinical examination?
I would like to examine the genitalia, the extent of hypospadias,
Local
whether
examination. You talk about local examination.
local examination, bilateral testes are descended or not, and whether bilateral ureteric orifices, whether the size severity of hypospadias.
Shreya, first thing would be size of the patch.
So now can you see the screen, sir?
Yes, we can see.
Yeah. Now you describe this case and then you guys can take over for Viva VC.
Okay, Shreya, describe local findings, examination findings.
Yes, there is severe epispadias with the bladder, bilateral ureteric orifices are visible with posterior wall of bladder probably prolapsing, and the defect is extending up to umbilicus.
Hello. Yes. So this patient comes to you in newborn period. Let's say his baby is 24 hours old. How will you manage this patient?
Sir, I would like to know if child is passing urine, like passing urine adequately or not. If the bilateral flanks are full or not, then I would like to proceed for a ultrasound KUB because it is associated with urinary system abnormalities, and also an X-ray. I would like to do a spinal examination and see for anal opening and whether child is passing stool or not properly, and an X-ray lumbosacral spine. And also I would like to see for on X-ray pelvic diastasis, the degree of pelvic diastasis, and also extremities examination, if adequate movement is there or not.
So what will you do now? You have seen. How will you assess that bladder patch is good enough or not?
Mm. Usually we wait for like 2 to 3 months for the child to grow, and we explain parents how to take care to keep a moist gauze over this mucosa, and presently it is very small. Presently it is a large defect and we cannot repair at this point of time. We usually wait for 2 to 3 months.
So actually, there are two schools of thought. Some advocate closing extrophy in the newborn period itself. So why should you close in the newborn period? What are the indications and what are the advantages of closing in newborn period?
There
And
might
what are
be
the problems of closing in newborn period?
problems will be it is a very small capacity bladder, and as soon as we close, there might upper tracts can get dilated because of small capacity bladder. It can generate high pressures. Also, there'll be technical difficulty in closing the epispadias part. Advantage will be it will prevent maybe recurrent UTIs.
What is another advantage? Closing the pelvis. Anything to do with closing the pelvis?
What?
Influence of maternal hormones, and you are able to close pelvis. Pubic diastasis.
Bony ossification, it will allow for.
Dr. Archana, are you there?
Yeah, I'm very much there. I'm listening to you. So, Shreya, when we asked you to tell us the findings, I think what a student is expected and what we do in OPD is that we have to comment on the bladder template, and you are seeing two bladder templates. The first image that was shown was of a good bladder template because it was bulging mucosa. And now the image that is there on your screen, you can see that the bladder is looking not that supple. No? So we have to learn to see the bladder template and to examine the bladder template to see what is a good bladder template. There is an element of subjectivity, but if you are able to push the bladder template in and it is soft and supple, then it is considered to be a good bladder template. Then epispedias. These patients never have hypospedias. They have dorsal chordae and short stubby penis that you have to say. And then you have to comment on the pubic diastasis. You can feel it with your thumb and you can measure the distance. You can confirm it on an X-ray. And these patients have anteriorly placed anus and low septum licus. So, and the hernia. Many times hernia may be associated in these patients. So these are the findings that are expected to be said in the examination. Then coming on to the philosophy of treatment, newborn versus delayed primary repair. What do you do at your center?
We usually wait, ma'am, for at least.
So during that period when you are waiting, how would you ask the attendants to take care of the bladder template so that it doesn't go bad?
We'll advise them to keep the mucosa region moist, the exposed bladder mucosa moist with wet gauze or Vaseline gauze can be kept.
Yeah, you can use that clean film that we use for sandwich also. In the West, that is what they are using it. Even in our OPD, sometimes we use that. And coconut gauze, coconut oil can be used to put it as a lubricating non-sticky dressing over it, and you can apply a diaper over it. Okay. Then you once said in your this thing that ultrasound should be done as these patients may be associated with genitourinary anomaly. So that I would like to differ because bladder extrophies are usually born with a normal kidney. The kidneys do go bad with treatment, but initially most of the babies would have a normal kidney. So most of the times ultrasound KUB is going to be normal. Spinal anomalies are also not that common. They usually have pubic diastasis, and the bone related issues are usually related to that rather than anything other than that. So what is the delayed primary repair in bladder extrophy? So delayed primary repair is a term that is being used when you repair the baby after 1 month of age. And in the West, there is a concept that they do the neonatal repair because as Dr. Mahajan was trying to suggest to you, that during the first 72 hours of life when we close, then osteotomy may not be needed and you may be able to close the pubic diastasis with it. But in our experience and also in the experience of many other centers in India, we have seen that the failure rate of bladder extrophy is much more. And it's difficult to manage these babies in the neonatal period. And so most of us would be going on for a delayed primary repair because any repair after 1 month would be put in that category. And then what are the other philosophies of treatment? Do you close everything in one go or you do a staged repair, or what are the various types of repairs that can be offered? In bladder extrophy, what are the types of repairs?
Like staged repair or single stage repair? Probably she has seen staged repair.
Yes, functional bladder closure later.
So Shreya, we can either do just for the benefit of the students, either we can do a staged repair where we go one by one. So the first stage would be like you will close the bladder up till the posterior urethra. What you should remember is you should not stop your closure just at bladder neck. always in the stage repair, the first stage is closure of the bladder till posterior urethra, till the point of verumontanum. And osteotomy is plus and minus. Many centers do it. Most of us don't do it. Then herniotomy is an important integral part. If hernia is present, then you should address the hernia repair in the first stage. And abdominoplasty. You have to close the abdomen, of which there are many ways. We will come to that. And then in the second, this is usually done as the first stage. Then the second stage would be an epispadias repair, which will be 6 to 9 months later. And then when the child grows up and becomes 3 to 5 years of age, then you will do the continence procedure. That is, you have to do a bladder neck repair with ureteric reimplantation. And later on, the child may merit an augmentation plus minus metrophenol. So these would be like various stages of a stage repair. But other ways of treating bladder extrophy are also there. Like you can do a combined bladder epispadias repair. Like if you see a child who is much older, like has come to you at 3 years, 4 years, then you can combine these two stages into one. And the combined bladder epispadias repair gives you a very good view, because everything is open like a book and you close it in one go. Because there is an area in the posterior urethra which is difficult to treat if you have not repaired it in one go. So the continence way, we have seen that continence is much better in combined bladder epispadias repair. The disadvantage being that since you are giving outlet resistance very early, so the kidneys go bad early also, because reflux is there and you have done the epispadias repair. So, and then some people would do everything in one go. So there are various philosophies of treatment. And then the second philosophy is to divert these patients. Sometimes if the child is coming to you very old or it is a failed extrophy, so there is one school of thought you must have seen at your center. I think your center has got a big series where diversion procedure is being offered to them. So as a student, we should broadly know what are the various philosophies of treatment and advantages and disadvantages of each.
I have a
Okay.
question. I have a question.
Can we? Yeah,
Very
please.
basic question to share. What is intersymphysial band and what is the importance of these bands in extrophy? Have you heard about intersymphysial bands?
Yes.
Okay, fine.
She has not seen, maybe she has not seen.
Yeah, it's okay. I mean, you should read about it. And it's an interesting thing. Extrophy is our strength. In India, we have a lot of extrophies.
So if I can just answer, so intersymphysial band is some people say it is a remnant of internal sphincter. No one knows exactly what it is, but it is very important to divide these bands. They are usually present in an area of bladder neck just above the posterior urethra, and they are attached laterally to the pubic diastasis. Shreya, are you there?
Yes, ma'am.
So when we are doing surgery, many of the failed extrophies, if you happen to do it again, you will realize that how many times intersymphysial bands are left, it is very surprising. So intersymphysial bands have to be divided, and they have to be divided close to the pubic symphysis so that you get a flap over your bladder. So once you have done the bladder closure, you will put it as a second layer. Buttress.
One last question as we are running out of the time. How will you diagnose antenatally bladder extrophy? And if you diagnose it antenatally well within 24 weeks, then what will you do?
Antenatally, there will be it will appear more like an abdominal wall defect.
चेंज हो गया तुरंत.
Yeah. So constantly, like on 3 ultrasounds, 3 settings of ultrasound, if you don't see a full bladder, an empty bladder, and a white defect in the abdominal wall, then you should suspect extrophy. And then you examine the genitalia, which is not allowed in our country. Then you will come to know that there is a dorsal cordia and there's epispadias also there. So if you diagnose it, what will you do? Suppose it's a sure shot diagnosis of extrophy, what will you do?
We'll explain the parents about the how it will appear postnatally and the about the multi-stage surgeries which are required, and we will give them
An indication of termination or not?
not from our side, sir, but if parents want, they can.
So it's not an absolute indication of termination, the termination of pregnancy. So very good discussion today on PUJ obstruction, such a common condition. You presented it very well, defended your questions and answers very well. And this time we have added the short case concept. For a few more weeks, we will do this and then we'll again change, keep it interesting. Thank you both the examiners, Dr. Mahajan and Dr. Puri, for giving your valuable time. Thank you all the participants for being with us. Thank you our president, Dr. Ramesh Babu, for joining. Thank you and very good
Thank
night.
you.
Thank you.
Thank you, sir.
Good night. Dr. Mahajan, Dr. Vikesh, good night.
Thank
Good night,
you.
Shreya.
Good
Bye.
night.